So there you were, on the scene of a collision. Car parts everywhere. All right. I clearly am not Captain Kirk. I can't do Bill Shatner imitations. Let's just try this again. Hey, you're on the scene of a motor vehicle collision, let's say. You have a guy with some point tenderness and shortness of breath. You're concerned that he might have a rib fracture. And you're thinking, hey, I know rib fractures can puncture lungs. Maybe, just maybe, there is a pneumothorax. And you ask yourself, what should I do for this potential pneumothorax? Well, let's say that there is a friendly x-ray tech just strolling on by, minding his own business, hump-de-dum-de-dum, with an x-ray. He takes an x-ray, shows you the x-ray, and sure enough, there is indeed a pneumothorax. And let's say it's maybe 5%, just a little apical pneumothorax up there, just enough for you to see. You assess your patient, you find out his heart rate's like maybe 102. He kind of hurts, you know, rib fracture. His blood pressure is 140 over 85. He probably eats a lot of salt, doesn't take good care of himself, but he's not hypotensive. Respiratory rate's around 20. Oxygen saturation on room air is 98%. But you see a pneumothorax on the x-ray. Do you need to dart the chest? We know that opening up the chest with a chest tube or a finger thoracostomy or a needle thoracostomy, a chest dart, is a potential treatment for pneumothorax. But do all pneumothoraces need to be opened up? Turns out the answer is no. Most of the pneumothoraces that I see, small pneumothoraces without tension physiology, the way I treat them is by not putting a hole in their chest. I put them on high flow oxygen with a non-rebreather. And the reason I'm doing that is not because they're hypoxic. They're not. Remember, this guy's SAT's 98%. The reason I'm putting them on high concentration oxygen is because that increases the partial pressure of oxygen in the thorax, and that increases the rate that that lung is going to re-expand. So the pneumothorax gets smaller faster with oxygen. That's why we put him on oxygen. And as a matter of fact, what I may do for this poor guy, put him on oxygen, repeat an x-ray in a couple of hours. If it's not getting bigger, he may get to go home. If it's traumatic, maybe I'll just admit him to the hospital and watch him overnight, keeping him on oxygen the whole time. So that gets us back to, when do I need to stick a needle in a chest? Only for tension pneumothorax. So what is tension pneumothorax? It is derived around physiology. What happens is you have air, much like Hotel California. Things are checking in but not checking out. You build up more and more pressure in the hemithorax. That puts pressure on the heart. When you start to squeeze the heart, you inhibit blood flow into the heart. That's called preload. Preload, if you don't have blood in the heart, you can't pump blood out of the heart, and you develop hypotension. You only need to dart a chest in the field for tension pneumothorax. No tension, no dart. No hypotension, no tension. Get it? See what I did there? No hypotension, no tension, pneumothorax, no dart. Guys, hopefully this makes sense. Just as a reminder, not all pneumothoraces need a chest dart. Not all of them need a chest tube. A lot of them get better just with oxygen. Don't let lack of breath sounds influence your decision about whether to dart or not. Darting is based on physiology, based on tension, based on low blood pressure. Guys, that's it. Y'all have a great day. You can check out anytime you